And the debate will be, can we build our decision for luminal breast cancer on Ki-67? Professor Gusippe will say yes, and Professor Nohat will say no, and we wait for the debate. Thank you.
Thank you. First of all, thank you for the invitation to this interesting meeting. And let me start with a very personal remark. Oops. Doesn't go? Okay. My personal remark is that, unfortunately, in this occasion, I couldn't choose the party. And so the yes has been assigned ex officio to a seasoned pathologist, that's me. But despite everything, I will fiercely defend the yes cause. Cliff has already pointed out to this molecular classification of breast cancer based on expression profiling, or some 500 genes, and all the breast cancers have been subdivided according to this expression of these genes in 4 or 5 main classes. And the luminal classes, they represent something like 70% of all breast cancers. And within the luminal, there are 2 main subclasses, luminal A's, that will represent approximately 60% of them, and luminal B's that will be the remaining 40%. So this is interesting from a biological point of view, and of course it is also interesting from a clinical point of view, because we know that this classification has important clinical implications, because luminal A's, they have a very good prognosis, whereas luminal B's, they have a worse prognosis. So one of the problems that we have is how can we distinguish between luminal A's and luminal B's? We have 2 main strategies. The first one is use of immunohistochemistry, and you know that we have those 4 immunohistochemical markers, which is estrogen receptor, progesterone receptor, HER2, and Ki-67. And we will focus, of course, on Ki-67 in this discussion, and a variety of molecular assays stemming from the original assay that was established by Chuck Peru. There are derived assays that are possible to use on formally fixed paraffin embedded tissue, most of them. And the first 3 of them, the PAM50, the combination of blueprint and MammaPrint, and the MammaTyper, these assays are intended to subclassify breast cancer according to luminal A, luminal B, basal-like, HER2 enriched. And then there are additional assays that were not originally designed to subclassify breast cancer according to the molecular classification, but just looking at the risk of relapse of these tumors, like Oncotype, MammaPrint, and EndoPredict. But we will assume that for endocrine, for ER-positive breast cancers, the high risk of recurrence will, and the low risk of recurrence, they will equate the luminal A's and luminal B's. So altogether, we have a list of possible assays that will help us in distinguishing between luminal A's and luminal B's. In 2011, at the consensus meeting in St. Gallen, it was put forward a new classification, if you like, of breast cancer that was intended to inform the choice of the systemic treatment. And you recognize in these new subtypes of the St. Gallen consensus 2011 the same designation as the molecular assays. Again, we have luminal A, luminal B, we have the HER2 positive, we have the so-called triple negative or basal-like. And it was suggested in that occasion not to use the molecular assays, but to adopt surrogate immunohistochemical markers in order to distinguish among these different classes. And in particular, in order to distinguish between luminal A's and luminal B's, it was endorsed use of Ki67 at a cut point of 14%. So, what about Ki67? I am pretty sympathetic with Ki67, but I think Ki67 as a marker is a son of a lesser god. And this is because, as you know, in the ASCO recommendation for the use of tumor markers in breast cancer since 2007, Ki67 and other markers of proliferation were considered not to be adequate in order to be used for prognostic subgrouping of breast cancer patients. So why Ki67 was disregarded as a means of evaluating the prognosis of breast cancer patients? There was a point in time, since a few years ago, if you were Googling for Ki67 images, what would happen is that you had this one as a representative of Ki67. The distrust in the assessment of Ki67 was mainly based on some true evidences, which was lack of reproducibility in Ki67 evaluation. This was because of technical issues, because of scoring issues. We didn't know whether it was enough to have a visual estimate of Ki67 immunolabeling, or if it was necessary to have a formal counting of Ki67 positive cells. We didn't agree on what to count, where to count Ki67. And maybe more important, there was an uncertainty about the clinically relevant thresholds for Ki67. Is it 14%, the correct threshold for distinguishing between luminal A and B? Is it 20%? Is it more than that? So, due to all these problems with Ki67 assessment, it was justified to try and to run an international effort towards harmonization of Ki67 assessment. And indeed we did it, and I think in the last few years we have achieved something important. Starting from the definition of recommendations in order to have harmonization in the technical aspects of Ki67 immunostaining, in the interpretation issues, in the decision of what to count and where to count Ki67. So we set a number of recommendations, and then we started a number of studies in order to assess the possible reproducibility of Ki67 immunostaining in different labs in the world, starting with the phase 1, where we distributed actual slides of Ki67 stained tumor samples to 20 different labs in order to see whether the way that we were scoring Ki67 was homogeneous or not. And unfortunately, in this first experiment, in this first study, there was a very bad agreement among the different pathologists. So it was important for us to prepare a kind of training set for the evaluation of Ki67. So we prepared a web-based model of training. We distributed this training to all the involved pathologists, and we have a second run where the agreement among pathologists was increased due to this previous training on these web-based images. And recently, in the last San Antonio meeting, we presented the results of the third phase of the study. In this third phase, we distributed slides of core biopsies of breast cancers to 22 different labs all over the world. And we achieved interclass correlation coefficient that was quite good, because we increased from the original 60 or 65% to 0.88 when the examination of the core biopsy was performed by these trained laboratories, looking at the entire width of the core biopsies, not focusing on the hot spots, because focusing on the hot spot had a lower interclass correlation coefficient, whereas looking at the entire core biopsies allowed us to have a quite good correlation coefficients among us. In 2013, again, the Gallen consensus was asked to try and find an immunohistochemical definition of luminal A's and luminal B, trying to overcome the problems with the original definition of luminal A's and B based on 14% cutoff for Ki67. Due to the fact that it was pointed out the important addition of looking at progesterone receptor together with Ki67 in order to differentiate between luminal A's and luminal B's, it was proposed to put together high Ki67, having increased the threshold for high Ki67 to 20%, not 14% but 20%, and adding the evaluation of progesterone receptor, low progesterone receptor, less than 20%, coupled with high Ki67 will be a definition for luminal B breast cancers. So with this addition, we went back from the Gallen consensus to Milano, and I wanted to double-check whether the 2013 definition of luminal A's and luminal B's was actually available and was working in the clinical practice. So we looked back at a consecutive series of more than 9,000 patients in our institution. These patients were treated between 1994 and 2006. We had data on long-term follow-up, focusing on distant disease-free survival. There was a team of 8 seasoned pathologists looking at these slides, and we were using standardized protocols for staining, interpretation, and reporting of Ki67. So we went back and we looked at all these cases, and what happened was that for patients whose tumors have very low Ki67, less than 14%, the addition of the progesterone receptor data didn't change the prognosis of these patients. All these patients in the panel A, they were treated with endocrine treatment only, and you see that the long-term follow-up of this patient was exactly the same, irrespective of progesterone receptor status, if Ki67 was low, less than 14%. In panel C, you see what happened to those patients whose tumor has high Ki67, more than 20%. Many of these patients were treated with chemoendocrine therapy, and you see that for these patients, the long-term follow-up was almost identical, irrespective, again, of the progesterone receptor status. It was only for the patients in the panel B whose tumor had an intermediate value for Ki67 between 14 and 20%. In this category of patients, the addition of progesterone receptor was important because according to progesterone receptor status, the long-term follow-up of these patients was significantly different. So we tried to propose a new definition of luminal A's and luminal B's according to our data, So luminal A would be characterized by either very low Ki67, less than 14%, or an intermediate Ki67 between 14 and 19% with high progesterone receptor. Conversely, luminal B either at high Ki67, more than 20%, or intermediate Ki67 but low progesterone receptor. Does it work in the clinical practice? Yes, it works, because when we stratify all our patients according to this definition of luminal A and luminal B, we had a significant difference in the outcome of these patients in a multivariable analysis that included the stage of the tumor, lymph node status, tumor grade, peritumoral vascular invasion, menopausal status, and systemic therapy. So at the multivariable analysis, this definition of luminal A and luminal B was clinically relevant. And the second important point is that according to this definition, some more than 50% of the patients will belong to the luminal A category, and less than 50% of them to the luminal B. That was as expected. The last question was, does this immunohistochemical surrogate of the classification correlate with a true molecular assay based on expression of messenger RNA? So we had the opportunity, looking at the patients enrolled in the MINDUCT trial, to review more than 4,000 cases, where we had the molecular profile of these patients according to the blueprint and the MammaPrint assays, and our central pathology reassessment of Ki67 and progesterone receptor and all the rest. You see here in this table, summarizing our results, that for Ki67 less than 14%, there is a very good correlation with the molecular assay, with some 93% of the patients whose tumor has less than 14% belonging to the luminal A category. It is with high Ki67 that the correlation is very low, because you see that for patients whose tumor has more than 20% or more Ki67, they will be, 50% of them will belong to the luminal A's, and some 50% of them will belong to the luminal B's. So there is no precise correlation between immunohistochemistry and molecular assay in this series of patients, according to the 20% cutoff. So the next obvious question is, who's the winner? Well, I think that we have to wait for the randomized clinical trials, for instance, TAILOR-X or MINDUCT, where we will have on one side the central assessment of ER, PR, Ki67 and HER2, and on the other side there will be the molecular assays. So the results of this trial will tell us who is the winner. Another consideration is that Ki67 is just one assay. We are looking for one marker. Molecular assays, they are very many. And unfortunately, the results of the different assays may be different. So an assay will classify a tumor as luminal A, and another assay will classify the same tumor as luminal B. So our problem will be, how can we choose the assay? Should we run all the assays? Should we make a majority consensus? What should we do with these assays? Once we will be able to standardize Ki67, the advantage of Ki67 will be that it is available everywhere, it is fast assay, it is inexpensive, and allows correlation with tissue morphology. And now a plea to Dr. Ibrahim. Please don't fire on the Red Cross, or don't shoot fish in a barrel if you prefer. Keep calm and love a pathologist. Thank you very much.